Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers. Today, a look at preventing a deadly strain of Mpox from spreading in the Democratic Republic of the Congo and beyond. Dr. Didier Mbayi Kangudie and Shannon McAfee, two leaders of a Johns Hopkins Center for Communication Programs-led initiative to halt the outbreak, joined Stephanie Desmond to discuss what the program has accomplished so far and what the termination of USAID funding could mean for the people of the DRC, Africa, and the world. Let's listen.
Dr. Didier Mbayi Kangudie and Shannon McAfee, thank you both for joining me.
Thank you for having us.
Thank you, Stephanie.
Today, I wanted to talk about the work that you, as staff of the Johns Hopkins Center for Communication Programs, are doing in the Democratic Republic of Congo, specifically work with the current Mpox outbreak. Kangudie, I wanted to ask you if you could sort of just lay the land out for us. What does it look like right now on the ground in DRC?
Thank you so much, Stephanie. The DRC, the Democratic Republic of Congo, is the current epicenter of the global outbreak of the Mpox or monkeypox, which was declared a public health emergency of international concern in August 2024. Currently, the DRC is affected in all its entirety. We have 26 administrative provinces. All the 26 provinces have reported at least one or several cases of Mpox. So those cases are spread across those provinces. And as far as our work as CCP is concerned in the DRC, we were mostly focused in two provinces of the 26, and that is the South Kivu and the Kinshasa province, which is the capital city. And currently, because of the security situation in the South Kivu, we have suspended all work in that province, and we are only focused in the Kinshasa province. So Mpox is a zoonotic disease that is transmitted from animal to human and ends up being transmitted from human to human. And in fact, it is that human-to-human transmission, which is not only the close contact, but also the sexual transmission that has now made the DRC one of the country or the country most affected by the Mpox currently.
I might add that while Mpox is historically endemic in Central and West Africa, the disease since the beginning of 2024 has spread to over 120 countries.
And how many in the DRC have been impacted?
Right now, there have been, as of last week, there were 89,000 suspected cases. Over 16,000 were confirmed and 1,600 deaths. It's important to note the data coming in is incomplete. So we imagine that the situation is much more grave. When Kangudie spoke about the conflict-afflicted provinces in Eastern Congo, I think this is a great example of where we're not able to get complete data and in certain moments not able to get any data.
And Kangudie, this is a different outbreak from the one we heard about in the United States a few years ago. It might also be deadlier, is that right?
That is correct. So let's just talk about Mpox. Mpox is a monkeypox virus. It's called scientifically an orthopovirus, similar to the smallpox. It was first discovered in a colony of monkeys in Denmark in 1958. And that colony of monkeys were kept for research laboratory. But the first human case was diagnosed in the DRC in 1970. That was considered as a clade 1 Mpox disease, which is a Central African clade. But then the 2022 outbreak was mostly the clade 2, which is the Eastern Africa clade. And now what has made this particular outbreak more deadlier is because the virus has evolved. The clade 1, which is the Central African clade, has gotten more virulent, and it has actually two types. It's clade 1A and 1B, and the one that is most sexually transmitted, that started in the eastern part of Congo, where we moved from animal to human, human to human by contact, to become sexually transmitted with high morbidity and mortality. So that clade is the one that is actually wreaking havoc on many lives in the DRC currently.
So, Shannon, what has CCP's work been to work to prevent the spread of this disease?
CCP has been a prime driver since the beginning of the response. CCP co-founded or co-developed the national strategy for the Mpox response, as well as the strategic communication plan for the Mpox response. And not only do we work at the coordination level, we also are implementing and executing the strategy. And that looks right now, as Kangudie said, we're working currently in 9 high priority zones in Kinshasa. This looks like support for 480 community health workers who work door to door through community sessions daily. And we reach about 200 people through the door to door, over 500 through community engagement meetings. And we are also broadcasting a campaign of both radio and TV, interactive radio and interactive TV shows, as well as radio and TV spots. And we broadcast these daily, 9 times a day for both the radio and the TV. When we leverage trusted voices, these efforts are really contributing to rapid action and reduced transmission, as well as stronger protection for vulnerable groups.
Yeah, I was going to ask you, first of all, that was 200 people a day that are being reached. And so what are you telling people, Kangudie?
So when it comes to Mpox, prevention is everything, because Mpox is the disease that requires contact. So people need to know, first of all, how is the disease transmitted? Because as we say at the CCP, communication saves life, knowledge is power. So empowering community to understand how the disease is transmitted is the first step to the prevention. And community are empowered through the information that be careful about this disease that is transmitted by close contact. Also, beyond the prevention, that the close contact, especially for human to human, we also address other ways of transmission, especially those who can get in contact with animals, because we know the primary transmission is animal to human. And DRC is well known for bushmeat. We have a rainforest, and a lot of the community tend to enjoy eating meat bush. And that contact with animals, especially dead animals, because that's where the disease originated from and spilled over to human. So the contact, how to avoid contact, especially they have been a habit of even eating dead animals. So these kind of information to avoid contact with dead animals, to avoid contact with people presenting with those signs and symptoms of the deadly disease, being fully aware, as we say, let's spread awareness and not disease. So giving the message on spreading awareness and not disease is really key to our work. And then the other information that we are also giving is about vaccination. As you know, in the medical countermeasures, vaccination is also an important pillar. And for people to get vaccination, we need to address the fears, the mistrust. As you know, there are a lot of disinformation around vaccine. So communicating around all those issues that prevent people from accessing vaccines is part of our communication strategy. So it's a really package of information around how to prevent disease, both in terms of hygiene and lifestyle practices, but also access to vaccine, which is really one of the tools in our toolbox against the
Shannon?
CCP has decades of expertise in social and behavior change. the work that we're doing is not just awareness building. It also is about problem solving and finding solutions that are community driven to the issues that we're dealing, these very complicated issues surrounding Mpox prevention and case management. And I'd like to give a couple of examples. One is when we think about Mpox transmission, there's the skin-to-skin contact. And children under the age of 5 are the most vulnerable. And mothers need to take care of their children. So imagine that you are a young mother with a baby who has Mpox. There's no way you can't touch your baby. There's no way you can't comfort your baby. And so we help find solutions to that. How can a mother take care of her child when her child is afflicted by Mpox and be safe and do the right thing in helping that child get treatment? Another example that I'd like to give is that men working in the mining industry, these miners who work on a daily wage, they're also extremely vulnerable to Mpox. And if they do get Mpox, their livelihood is in danger. And they may not be very interested or willing, let's say, to give up this to go in and get treatment and care. And so we need to work on, and we are working on ways of addressing the structure. So working with the companies themselves and the social network to support people who are working on a daily wage to be able to go get the treatment and not have to lose their jobs and not be stigmatized. So there are complex problems that we are dealing with that really go beyond awareness building, but go into really the depths of behavior change and working at the community level to find, like I said, community-driven solutions that are practical.
So I wanted to ask this. This project was terminated by USAID as part of the federal cuts. Then you received a waiver to continue the work, but that waiver is about to expire. I'm just wondering, Kangudie, what this means for the people of DRC and for the potential of this outbreak to spread beyond Africa.
Yeah, Stephanie, that's a very good question. For those who remember the outbreak of Ebola, we used to say Ebola anywhere is Ebola everywhere. And the same applies to Mpox. Mpox anywhere is Mpox everywhere. And Mpox in DRC means that being the epicenter, the potential for neighboring countries, some of which have already been affected, Burundi, Rwanda, Tanzania, some cases have already shown up there. In 2022, it also reached the shores of Europe and America. So the reality of the DRC being the epicenter is that if left alone, the potential of it again upsurging to reach the shores of other countries, including America, is still very, very, very high. Now, the government is supposed to take the lead. And all the good work that Shannon described we're doing, we're not doing it on our own. We're actually supporting the government. The government has set a system in place, the incident management system that we are supporting. And that management system has several pillars. One of the pillars is the risk communication and community engagement. This is what CCP is supporting. That pillar of risk communication and community engagement, which is really community empowerment and community protection, is not well funded because there are always people rushing to do case management and other pillars, laboratory also support and surveillance, but very, very few partners are actually funding risk communication and community engagement. So I see a lot of trouble if people believe that taking care of case is enough and ignoring community engagement, community protection, information. It is going to be a tough time ahead of the DRC. We're hoping that Africa CDC and other partners can actually chime in as we actually winding down to actually support the government. And many in the African continent are now saying, with the US government withdrawing its support, it's time for African government to really step in to strengthen the healthcare system. There is what is called the Abuja Declaration that actually require government to fund their health with at least 15% of their budget. very few countries. The DRC is maybe about 7% or less of their budget funding health system. So it is time for African countries, and in this case, the DRC government, to step up and put money into the Mpox response. But until that comes, there is a gap, there's a vacuum, the people are going to die. The waiver was well labeled life-saving interventions. Yes, it did life savings. Now we're winding down, we're closing out, we see problems coming. And I don't want to predict what may come, but I'm seeing a lot of challenges in terms of sustaining a response that can really put an end to the transmission of the disease.
Didier Mbayi Kangudie and McAfee, thank you both so much for joining me.
Thank
you so much for having us. Yeah.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.